make sure this thing is working. You have our bios, and we'll send you it afterwards. And I know Kara, who's in the room, who I haven't had a chance to actually meet, but I'm looking forward to it because we're counterparts in the industry. But she's going to focus on implementing a health center and best practices around that later. And I think you'll see some integrated themes here in terms of these best practices, and we've heard a lot about it this morning from the different panelists, and that's been great information. But we're kind of trying to look at, what are best practices, what are common mistakes that employers make, what are common mistakes that consultants make. I know we're consultants, we don't actually have any skin in the game, but we do make mistakes. So I tried to take kind of a comprehensive view on this and get other people's perspectives, including, understanding the legal issues as well. So what you'll see in this presentation is a little bit of everything, a proposed process, and then kind of some thoughts about where those opportunities are strong or where there's gaps or opportunities, and you'll kind of see these insights throughout. But as I sat down to put this presentation together and recognizing I am in between employers, and I don't have any access to any Mercer materials, and I'm not with Alliant. But I thought about, how can we shake this up? This is actually a presentation that I've given at least 2 times before for NAWHC, and I didn't want to just dust off, what I've done in the past. I wanted to think about how I could do this differently. So I stepped back and I thought, why don't I approach this in the way that everybody's talking or thinking about or nervous about? I'm going to ask ChatGPT what ChatGPT thinks about what best practices are for planning a health center. So the core of this presentation really is the results of what I asked of ChatGPT and what it produced, and I'm going to use that as a framework for speaking to the things that it missed, including the perspectives of the broker community and the employer clients that we work with. So verbatim, this is what we put into the system. Create a detailed plan for an employer-sponsored clinic, and its initial response, which is followed by a 15-point plan, is create a detailed plan with these initial setups. So what you're going to see on the next slides are each of the individual responses, and we'll speak to kind of where we think they missed the mark. Anybody nervous? I know I am, because ChatGPT is going to put me out of a job. So needs, I'll give you a second to read through exactly what it said. And I'd say it broadly, kind of the level of content that's in this individual output is consistent with each of the other 14 items that it's going to produce. And I'd say it's fairly limited in the level of detail that it provided. Could I have prompted it with more information and to possibly fuel more detailed results? Possibly, but this is what it provided. And I'd say right out of the gate, I think in terms of, we talk about order and approach, thinking about needs is the correct first step. And I think it's a thing that everybody needs to do right out of the gate, and we see it as a mistake of many of our clients that we've worked with, that they're not taking the time to clearly define what their objectives are. They're not taking the time to understand the needs of their stakeholders and clearly document that as a foundation for their process. They're jumping straight to, well, I heard about a model that somebody else had, so I'm just going to talk to a specific vendor, or I'm going to jump to a feasibility study, and we're going to look at the ROI of X model, which they might not have even defined yet, or they're going to jump right to an RFP and just ask vendors to bid without telling the vendor community what the model is that they want to see. So I think right out of the gate, this is generally the first step that you wanna take. But I think there's probably in 45 minutes we're not gonna have a chance to cover every little question, and even in prep I was getting some great questions about things that we need to think about. But I was trying to think about other major gaps that I was seeing in what it presented to me. Another key thing that you really need to start with is thinking about this from a stakeholder perspective. Do we have the right stakeholders at the table? Whether it's a new clinic or a redesign, who are the stakeholders within an organization that potentially could benefit from a worksite clinic? And I use that in air quotes, that it means many different things, and it should be designed to fit the needs of the organization that it serves. So stepping back and making sure we have the right people from HR and benefits, we have the right people from risk, occupational health and safety, amongst others, so that we're sitting down collectively and understanding what is the problem that we're trying to solve, and that will tee us up to design a model that is customized to fit the needs of that population.
David?
Yeah.
Can I ask a question?
Yeah.
Even the first step is everyone else is doing it. Is it pain that causes them to do this? Is there healthcare costs? Is it opportunity? Do they need better stewards of my people? Is it all the above, or is it? I mean, why would they even consider? Why would most employers even consider kind of saying that?
Yeah. Everybody comes at it from their own perspective of why they might start the conversation, and then I think it's stepping back and understanding, and data is a fundamental piece of that, and you'll see that in subsequent steps that's recommended here. But looking at data, understanding the population that potentially might have access to this, what are their cost drivers, what are their health conditions, and medical is typically just one component of the puzzle, and those objectives, as you define it for an individual employer, are always going to be somewhat different from others. There may be commonalities and we saw it in the survey results this morning, that there's typical ones that are high on the list, but it might not be the same for everybody. In a rural environment where there's primary care access issues, or there might be, if you're focusing in manufacturing, there might be emergency response time issues with getting from a hospital or an ER to the work site and through security. It's thinking through all these different issues of, what are the problems that each of our stakeholders have, and then collectively that will make up the specific objectives that are relevant to you as an organization. Did that answer your question?
Yeah.
Kind of.
Well, there has to be a reason why they're even stepping into the water. I understand the needs assessment, but it's. I would think that most of us realize healthcare is a shit show, right? I mean, we know that it's just not functioning the way it's supposed to. And
Right.
So I was curious whether cost is the number one reason why employers consider this, or whether they actually think there's a better way to take care of our people.
I think it's variable, and I think employers' understanding of why it's broken is different, and that's part of why having different stakeholders at the table, including outside consultants that can give a different perspective and help explain, or identify why it's broken. But in a rural environment versus an urban environment, it could be two different things, just as a simple example. So step 2, legal. Here I also agree with them, and we always say from a consultant perspective that as much as we understand the different issues that need to be considered in the decision-making process, as well as leading into an implementation plan, we are not legal counsel, and we need to lean on experts like Stephanie and her team to analyze potential decisions, as well as provide a specific plan. But Stephanie?
Hi everyone, thanks David. And just like David said, I am legal counsel, but I'm not a consultant. So when you're doing your RFP and have 10 people to choose from, right, it works pretty well to have a good consultant to help with that. So as I was, well, like David said, we also did not practice this very much, so we're kind of both just doing our thing here. I tried to think of about the 8 things that I always start with whenever a client calls me and says, either I'm starting my own clinic and I want to involve a clinic manager or do it myself, or I'm transitioning clinic vendors, which is more likely the calls I'm getting. And then I also work with a lot of vendors too. So flip side of that, working with the on-site clinic manager when they are transitioning away or to a new client. So here's kind of my list of 8 that I'd recommend, and happy to email this to anyone since I don't have a slide. But one, just vetting your vendors. So from a regulatory, from a legal standpoint, we have a vendor vetting form that we use. We have one both for just cybersecurity alone, but then everything else. So, how do they handle compliance? How do they handle cybersecurity? What's their litigation history? What's their licensure? What are their template forms? I don't know if that's something you ask for in RFPs, is template forms, but that's always helpful because a lot of the clinic managers do have a somewhat standard form they use, especially depending on if it's on-site or near-site. So I think that's really helpful because when you vet your vendors really carefully, it's gonna make the negotiation process that much easier. You're gonna find out, you know, any issues. You might find out, oh, they did have some litigation. Why was that? Easily explainable, or oh, this was an issue, and now maybe they've solved it. The second thing when you're planning or implementing a clinic is your clinic management agreement. So again, we kind of have a list of, literally a checklist we go through to see if they have things in it. So like your detailed metrics and performance guarantees, will there be any of those? How detailed is the statement of work? Does it go through all services? One of the biggest things we talk with clients about is planning for the divorce. We hope that if you're an employer, you work with your clinic manager for many years. I love it when my clinic manager clients have long-term relationships with employers. But you know, all good things come to an end. People want to transition. People want fresh people in. It just happens. And so that's probably one of the biggest things that I see people not think about in the implementation because they're so excited about their new clinic manager, right? And so what are the notice periods? Can the clinic manager terminate the employer quickly, right? Can the employer terminate the clinic manager? Is there required transition planning? Lately, we've had a lot of issues, and I'm in Indiana, a lot of issues with restrictive covenants there, and how easily can physicians or nurse practitioners go and stay with an employer when you transition those clinic vendors. And we actually had a new law passed that for agreements after July 1st, 2023, restrictive covenant agreements, so your non-competes are prohibited now for primary care doctors, so family medicine, pediatrics, and I think internal medicine. And then there's some other limitations too. So just understanding those. And then another really big one we've seen lately is who controls those vendors. So if you have an on-site clinic manager, but then you also have, let's say, a telehealth company, an EAP provider, behavioral health, pharmacy, you know, do all those contracts will rest with your on-site clinic manager so they have the ability to change those, or can you hold on to those? So those are just some of the things we like to think about with a clinic management agreement. And I know, David, you said something at lunch that was interesting, how I think you said in RFPs, one of the things you like to put is there a restrictive covenant agreement or require there not to be? So if you're working with someone who understands the RFP process well, they can even set you up to make that negotiation of the clinic management agreement easier when some of those discussions have already been had versus when we're, you know, trying to get a contract signed by a deadline. The other thing when implementing a clinic is understanding the corporate practice of medicine. I'm not going to spend much time on that, but some states require that a licensed practitioner own the company that provides the on-site clinic services. So if you have a nurse practitioner or doctor on site, can that be owned by the employer themselves if they run their own clinic, or do you have to have a physician that owns that? And then licensure, that's another big one. For the most part, I have seen the clinic managers that are here understand that. They're gonna likely handle all that for you. It's more if you're running your own clinic, understanding can you do on-site dispensing. Today I learned Georgia recently changed their on-site dispensing laws, where now only MDs can dispense on-site, you know, and so just understanding those type of things. Do you need a pharmacy permit, CLIA permits? That's been a hang-up I've seen a few people get into. The next one on my checklist for implementing a clinic is data sharing and medical records. It's huge. It's such an important point. In fact, I stole this from Catherine Quadracci. Frictionless, coordinated, data-driven. That's what we should all be trying to go towards, right? But if you're gonna do that and be data-driven, you have to understand who owns the data, right? The medical records the provider typically owns based on state law, but what about all the other data? Who owns that? Is it the clinic manager or is it the employer? And how can that data be shared? Can the employer, HR, or the self-insured plan get PHI? The plan may be able to, HR should not. But can they get de-identified data? Can your clinic manager use your own de-identified and aggregated data for their own purposes, for benchmarking, statistics, right? And so that is something that I even recommend, and I don't know if you're gonna speak to this, in the RFP process, you guys are talking about data a lot. How that's being shared. Is the PBM getting data? Is your TPA getting data? Your PSA getting data? And what does that look like, especially, again, upon termination? Last three things are compliance. That is on my implementation checklist. So especially if you're going to be running your own clinic, just really having a great compliance checklist. So we talked a lot today about mental health services, even beyond what EAPs offer. And we work with some clinic managers and employees that offer substance use disorder services. But for that, for example, you're going to have a federal law called Part 2, 42 CFR Part 2, that is very, very, very stringent on privacy. So, you know, David had well, no, not David, ChatGPT put HIPAA up there, and David put it on the slide. But, you know, think of Part 2 as HIPAA on steroids as far as what can be shared and how it can be shared and the different consents needed. So just really understanding the scope of services and what that does from a regulatory standpoint, especially from a privacy standpoint. And speaking of scope and services, that's the next one. So if you're implementing a clinic as part of the RFP process, and again, I'm going to defer to David on this, I would think that you are sometimes talking about what type of practitioners you're going to be using. So your physician assistant, nurse practitioner, medical doctor, maybe a medical director, physical therapist. But that's going to be really, really critical, and especially if you're an employer that's running clinics in multiple states, you're going to have a different scope of services depending on that state. So your NPs in one state may be able to, you know, prescribe unlimited C2s or C3 through 5s, other states that may be limited. So just understanding the scope of services, which of course is going to impact cost and legal restrictions and capabilities. And then the last thing on my checklist for implementation is benefits. So I'm not a benefits attorney. I know enough to be dangerous. I rely on Keyt and other people like that, but ERISA is always going to be important, your plan design, COBRA. And then lastly, what we talked about at the morning session was if you have a high deductible health plan, an HSA, whether you need to charge fair market value, which you do and you should. And I know we talked about this morning, I've never seen any litigation on that. Have you guys?
No.
Never. And we just always say keep your documentation as to how you determine fair market value. So if you ever do have an IRS audit or there's ever any questions, you can demonstrate how you determine that even though there's no specific formula. So tomorrow I'm going to talk actually about ChatGPT and AI and kind of like hot legal topics, but these were my implementation things, and I'm going to turn it back over to David. Thank you.
Thanks, Stephanie. I actually have one follow-up question for you. I mean, we talked about process and timing, and I'll refer to it as we go through each individual step, but from a timing perspective, obviously decisions can have implications related to regulations. Like, when should your advice be brought into the process?
Yeah, so I don't usually get brought in right at the beginning of an RFP process, and in fact, usually by the time I have been brought in, there's been some vetting of vendors, and I'm either brought in when we're at like 2 or 3 vendors, and maybe there are some things from a regulatory perspective, scope of services, are you going to do on-site dispensing or pharmacy they want to go through legally with, or it's once the vendor's been chosen, when the clinic management agreement starts to be negotiated, when the statement of work, when the data sharing agreements. That's the other time that I really get brought in if you're using an on-site clinic manager. If you're not using a strong on-site clinic manager that has a pretty good regulatory and compliance team and you're doing it yourself, I get brought in very early then because there's so many legal implications in how you manage a clinic on your own. So good question.
Great, thank you. All right, step 3, budgeting and financing. The recommendation is produced generally is saying to create a comprehensive budget and explore funding options. Fairly simple. While I agree with that, that we need to project costs, and it's generally as part of a broader feasibility process, I think this is putting the cart kind of before the horse from a process perspective. At this point in the process, we don't know concretely what services we're going to be offering, what staff members are going to be required to deliver those services. And I'd say in general, as you'll look back on the 15 steps after we get through it, you'll see that there is no recommendation specifically to put together a comprehensive feasibility study. And I think that in our terminology, when we think of that, we're really thinking about putting data to the decisions. We're looking at trying to project costs as well as the associated value on investment, run that through some different sensitivity analyses to understand the potential value on investment to the employer. And I think that it's a critical step as part of a broader business case. And a CFO, when it gets to that point, is going to be looking at this proposed budget, and they're going to want to know the value of the organization and have detailed data to support whatever the recommendation is. So I think it's a missed opportunity.
Can I ask a question about that?
Yeah.
As far as what you do, so I know when I'm negotiating contracts, it's always about performance guarantees, and they're asking, you know, what should this dollar amount be? Really, that's not really a legal question. So does the budgeting and financing and feasibility tie in to how you determine the performance guarantees at all, or is that really separate? Is that something consultants help with, or who's making that decision as far as those monetary amounts on the guarantees?
Yeah. You always need a consultant.
I know that.
But I'd say that the entire process is put you in a position where you understand why the costs are the way they are and build it from the ground up. And we typically use a foundation of more of a cost plus model where we're at the line item level projecting what costs will be based on utilization, services, staffing, and that framework ends up being the foundation for negotiations and choosing a financial model. And one of the steps here is that you need to pick which financial model is the best for your organization. You saw in the data this morning that the majority of clinics operate on a cost plus model, and there tend to be reasons for that, but there's other models out there. So even if you get into near site models, which tend to be PEPM or a per participant price, understanding the cost plus ground up cost plus model is going to provide you a foundation for negotiations and understanding what the true cost is, depending on what side of the table you're on. But it's a good question. So location and facility, on this one I'd say that ChatGPT did pretty well in simplicity. The location of the clinic is really important. Understanding security checkpoints, parking and proximity is all fundamental. But I think the things that it missed, phone call. It's all right. When you think about the facility, and there can be different thoughts in terms of if you're designing a primary care clinic versus an occupational health center in terms of the choices that you make. But particularly in primary care, our clients are typically looking to differentiate themselves from a community-based option. And the entire design process is fundamental to that leads to the best possible patient experience, which leads to positive word of mouth, repeat users. And there's building that from the ground up is really important. So it's also dependent on services, staffing, utilization, how much space you need, and we have models that can support the projection of that. And we're trying to avoid mistakes down the road as well. So some clients choose to kind of put their toe in the water and say, we're going to start with an acute episodic model, and it's just going to be a nurse practitioner or an RN, and then they want to grow into full-scale patient-centered medical home ancillary services. But to get to that point, you're going to need to have the available space. So you need to think through all these design options, including some of the high-end advanced primary care facility design choices around exam rooms that are more than the 80 square feet you see in the community, 120 square feet. Understanding the process flow if there's going to be ancillary services of how a patient's going to work through the facility. Understanding those things up front will arm individuals to work with facilities managers or other stakeholders in the organization to find the right space and configure that in a way that it's going to lead to the best possible outcomes. So I think that's really important. And then another kind of topic, and I've heard some of this in the panel discussion this morning, is that we're evolving. Things have changed since I started doing this with Bruce Hochstadt 15 years ago. At the time, EMR adoption was at 10% back in 2007, 8, and now it's a completely different world. Facilities, have always been a rate limiting step. You have to have X number of square feet, X number of belly buttons to support it, and it's been a challenge to find a space in a high profile location or the right location. But that's all changed. So the modalities of, and particularly accelerated through COVID, the prevalence of near site options that can be shared with other employers, the models that support pop-up clinics or temporary clinics, but most importantly, that virtual overlay that Kara spoke to this morning, that kind of changes the game. Benefits parity has always been an issue with clinics, that they're only serving the largest corporate location, but now we need to step back and think not do we have enough space to support our corporate headquarters, but how do we design a model that's available to everybody? And how do we scale that depending on the needs of each individual location to efficiently deploy whatever service we're looking to offer? So the game really has changed from a facility perspective. There's still best practices in terms of designing bricks and mortar, but it now needs to work as part of a broader integrated ecosystem, and that it starts early in the planning process to make sure you have the right infrastructure in place. Step 5, and again, this order is set by ChatGPT. So staffing, I said this was out of order, and notice the gap in the previous decisions. We don't yet know at this point, according to ChatGPT, what services we're going to offer, and that will lead us to what staff. There are individual decisions, as many of you guys know, choices to make, and in terms of just basic ones, physician versus mid-level, different credentials that different staff members might be required to hold. And I use this point in the process to emphasize, and this applies to the entire thing, that one of the core benefits of an employer sponsoring a clinic is that you have complete control over the design. And that is, it's really a tool that you can deploy. It's not the strategy itself, it's a tool or a tactic that supports a broader strategy. And your ability to make specific choices in that design process is fundamental to this being delivering a differentiated value, whether it's primary care or OC health or specific ancillary services. And I use, like, the second point here, ChatGPT recommends focusing on recruitment. And this one, may appear like it's kind of out of place, but I do think it is an important one, although one that's less discussed. And most, the majority of clinics are operated by third-party managers, and they really manage the recruitment process. So you're kind of fighting for a seat at the table. But I use an example of an employer, a high-end law firm in Manhattan, who early in the process, part of the data collection, not looking beyond just medical pharmacy claims to understand the population, was we reached out to and did focus groups. We did stakeholder interviews. We really got to understand the organization and their needs. And one of the things we uncovered as part of that process was the fact that their partners wouldn't see a provider that didn't go to an Ivy League school or wasn't a physician. So we knew early on that a nurse practitioner, and out of the gate, their benefits director thought that a nurse practitioner would be the better model. We found out early that that was gonna be a huge barrier and something we needed to change path on. So we introduced, as a result, we introduced that early in the RFP process. It informed the model that we went to market with. It informed questions that we were asking in the RFP process about their willingness to comply with the requirements of that employer. And that was one of many unique things that organization needed. So it's one example of many, and kind of the more information and data you have early in the process, the more it's going to identify potential roadblocks or barriers down the road. Services, we finally got to services. Again, not enough detail in terms of what ChatGPT is offering here, and it's a little bit out of order. And the decisions here, and I think of things as much as I want to be just a longitudinal path. It's a decision tree, and things are interrelated, so sometimes you have to back up and reevaluate things. But this is really dependent on staffing, facilities, budget, and what you're able to offer. You may want to offer the most comprehensive health center that has mental health, health coaching, physical therapy, but go back to my law firm client. They didn't have space in Manhattan for 1,000 square feet for physical therapy, so they had to kind of strike that service off the list. But this is really where data starts to inform your decisions. Understanding the needs of the population, a kind of fundamental piece of this is economies of scale. Do we have enough people to justify having this service on site? What does that mean from a staffing perspective? Is it going to support 40 hours a week? Can it be a part-time model with the pros and cons of that? Are there different ways to contract around that? So physical therapy might be one where maybe it doesn't make sense from even a part-time model, so you could outsource that to a local physical therapy organization to come in and do that on a fee-for-service basis, but pros and cons of that also. But you have to kind of inform this with data, and then make individual decisions and run it through feasibility model to understand what the potential outcomes of this might be, including running sensitivity analysis based on utilization and program impact. Technology and equipment, again, a woefully short recommendation. And I think we kind of dove, again, deep into technology in the panel discussion this morning. The recommendation here is basically to have an EHR, and that used to be groundbreaking. It's not anymore. There's so much more that a medical record does, or that this technology platform does than just being a medical record. And I really view this, and I agreed with a lot of the comments this morning, I view this from the perspective of thinking about it in terms of functionality. How is this going to serve the needs of the employer? How is this going to serve the needs of the providers that are using it? How is this going to serve the needs of the patients and their patient experience? So if we are, it's one thing if in the design process, and we're trying to solve for XYZ problem, that we choose to go down the path of an advanced primary care model. And part of that is population health analytics and the ability to risk stratify and do predictive risk and really drill down and identify potential future high-cost claimants. We need sophisticated data analytics to be able to do that. So that's going to lead us in one path. But if that's not the path you're going on, if you're just focused on a basic acute model, then you don't need that. So you kind of have to work through in each individual area to make decisions about, what is the functionality you're looking for. And once you get to the RFP process, that helps avoid mistakes. Choosing a vendor that doesn't have some of the necessary functionality that meets the standards of a particular model, or overpaying for a model that you don't need. I'm sure the vendors would like to charge as much as they can. So I think it's important to think through that stuff and think about it from different lenses. And I think that's sometimes in vendor relationships, in RFPs and finalist meetings, there's not enough time to dig into the 150 standards that NAWHC defines for a patient-centered medical home. You could spend 2 hours just talking about patient experience or one individual lens of what it takes for a model to be fully functioning. You got to pick your areas of importance and rank them in terms of where you're going to focus, and try to make the best use of your time. Hours of operation. This one, it probably doesn't need to be emphasized as much in the planning process, although it is important. It's more of something that's going to lead or be a barrier or a challenge in the implementation of the administration process. Up front, I think most employers are trying to target having a 40-hour-a-week health center just to provide convenient access during business hours. But there's different ways to configure that based on the services or the kind of the patterns of employees being on site, particularly in today's environment where they might be on site 1, 2, 3 days a week. I think another lens on this is that, and a mistake that employers make is that they're not actively monitoring this, that they're, and particularly in the early days of a health center in the first month or two, they're not watching when employees are using it, and you have to upfront think about shift schedules and make sure the clinic's available when people are on site. But then it's understanding when are they coming in and why, and drilling down into that data to make changes. And some of that could be at the policy level. Maybe there's managers aren't supporting the health center and aren't allowing people to go during the core business hours, and that could be a problem you have to solve for. Or maybe you have to shift how you're deploying staff to be available when employees are available. So I think you need to proactively plan for this step and to be actively monitoring it and make sure the vendor partner you have is giving you the data to make those choices. Employee education and engagement, and now some of these titles are getting a little bit vague. I'd say at a high level, it's hitting on the right themes that we need to communicate and market this service. Here it's blending communication with wellness programs, and going back to my comment about this being a tactic versus the strategy itself, I view this as two separate things. I think the health center and the vendor partner, or if you have one that's outsourced, they are going to provide wellness programs as a service like any other service. Here I think it's being presented more as a marketing or communication strategy in itself. Wellness programs and however you define that, create foot traffic and opportunity for engagement and opportunity for cross-referral into other service lines. It's not a communication or a marketing strategy in itself. The more services you can offer on-site, the more it's going to create foot traffic and opportunity for an integrated care team to support population needs. Data analytics and feedback. Again, this one's, I've kind of referred to it as part of other steps. This is correct. We do need to implement a system for collecting and analyzing data. And the more data a clinic manager has, the better they're going to be able to serve the needs of the population. Sometimes you'll run into barriers in terms of why medical claims aren't available to be shared, or they choose not to do biometric screenings. But the more data that they have, the more it will support their ability to effectively manage the health of the population. And I like the focus on continuous improvement, and that is dependent on having the appropriate data analytics in place. But I also kind of go back and think about it from the needs of the population again, and the model that's been chosen. What does, as you've asked a health center to perform a certain function, and I like advanced primary care because it's the more complex, what does a care team, whether it's a single physician or comprehensive care team with care navigators, behavioral health, health coaching, what do those individuals need to do their job the most effectively, and back it out from there. So I think you want to, and go again, I mentioned bringing stakeholders and governance structure as an important initial step. I think early in the process, as part of that survey process with the stakeholders, you want to understand what are the problems that they're trying to solve for, what are the questions that they're going to be asked about this model as it moves forward, and what's the data that you're going to need for them to answer those questions. That's going to help inform them in being effective managers of whatever the chosen clinic model is. So just some things to think about. Vendor relationships. This is valid, as Stephanie mentioned. The clinics, for the most part, particularly in third-party contracts, it's going to be a subcontracted relationship. They're going to bring to the table a lab partner, supplies, the necessary vendor partners. You might have other ancillary services you choose to offer on-site in addition to that clinic manager. So you need to think through it from an administrative perspective. And as well as a vendor might come to the table with partners. Lab is a very common one where you have the option of running it through the carrier versus a direct contract with a third-party manager. You need to push on all those relationships and understand the pricing that they have negotiated that's in place. We've pushed on the pharmacy component, we've pushed on the lab, and it's not always the simple cost savings that might be communicated in the sales process. But there is a benefit to having that all be under one contract. It reduces the administration and governance responsibilities from you as the individual sponsor. So it's some things to plan for or think about in terms as you work through the decision-making process. Health and safety protocols. This is another one, and Stephanie, feel free to weigh in. This is one that most employers don't spend a lot of time on, usually because they're outsourcing the risk in engaging in a third-party relationship. If it's an in-house model, that's another choice, and you really need to spend more time thinking about it. And from an RFP perspective, we ask some basic questions to understand the protocols that they have in place to understand or identify any potential quality concerns that might be present just operationally. But it's typically not one that I would raise to if you're going to identify the 15 most important things to put in a plan. I'm not sure I'd put it at the top of the list from my perspective, but.
Yeah, I mean, even if an employer's managing their own clinic, usually the physician is, and nursing staff is going to be in charge of the OSHA requirements. The one thing we have seen since COVID is, broader than COVID, in an RFP that I was looking over, is I review the RFP to negotiate the clinic management agreement to make sure everything matches up, and there are promises that aren't made in the RFP or that are made and aren't carried through. But it was, not so much infection control, but what if there's another
legal contracts and agreements. We've referred to this a few times during the presentation. You know, regardless of in-house versus outsourced, you need your legal representation at the table and to inform your decisions. And I think Stephanie referred to the fact of kind of thinking 2 or 3 steps down the road will really pay dividends in terms of simplifying the contract negotiation and not stepping into a situation where you're in the middle of, you've already awarded the business and all of a sudden you're in the weeds of developing the contract and you uncover a big red flag that they're not willing to move on because you've lost your leverage. Moving all those things up front and having a conversation about what are your business requirements, what are the minimum things that a vendor's got to agree to, that should be something that you kind of start with as an opening gate, that if to participate in the RFP process, they have to agree to those things.
Yeah, and even in the RFP process, I would say that even more legal issues like indemnification, if you're going to require the clinic manager to indemnify you, and insurance providers is up here, but I think more importantly is if you're working with a clinic manager, what type of insurance are they carrying, right? What's their cybersecurity liability? Is it 1 million or is it 10 million? Will it name you as an additional insured primary on their policy or not? And so thinking through those things, if you can have a lot of that in the RFP, it makes the negotiation process a million times easier and smoother than when all of that is left to, just the management agreement.
Yeah. And another piece that you referred to earlier in contract design, and it's an element that we frequently see missed, and it causes conflict, particularly when a health center is underperforming or there's debates about service levels in the future, and clinics evolve over time, and addendums need to be added, but a mistake that we see commonly is just that not enough detail is put into the agreement under the banner of service level definition. There's a basic description of primary care services or OC services, and may even list, bulleted out services that are made available in the health center. But these are complex operational models that the vendor doesn't want to get into the nuts and bolts in putting it into the contract. But as you're talking about what it takes for a health center to be a highly performing health center, that is at the granular level, and there needs to be no doubt about their willingness to comply with standards as if it's written by NCQA or AAAHC or whatever third party. Those level of detail need to be in the contract so that there's no question. Kind of planning for the divorce kind of detail of you said you're going to do X in the sales process. It wasn't mentioned in the contract, and now we think the clinic's not performing because of it. Like let's have it be no doubt. Let's put it into the contract, and there should be no fear about doing that.
Yeah, and even if you're not going to have performance guarantees with the service levels, you should expect or ask for monthly reporting from your clinic manager too on different service levels and everything, so you're not left wondering after 18 months what happened here, right? And so there should be a really good reporting mechanism in place. And then another thing too, we've seen especially with new clinics is there's a lot of honestly intellectual property that goes into it, whether it's being branded, with a new name, new colors, new logos, all the pamphlets and everything. Who owns all that? That goes along with the different services being provided, because when you transition vendors, are you the employer going to have to recreate that? Potentially, and that may be fair depending on how you set that up, right? But maybe not. So I would just say more detail is really necessary. And then you mentioned too addendums. And when something in the contract is not working and you aren't actually doing what the contract says, and everyone's okay with it, just please do an addendum, because there's nothing worse too than a year later when we look at the contract and you probably some of us are like, well, this isn't in the contract. You're like, oh, that's fine. We didn't think we need. No one wanted to deal with attorneys and getting an addendum, right? It makes it really challenging then when there is an issue. So that's another thing we do a lot of, like change orders and addendums too on these frequently.
Yeah. And I also want to point out that we talk about responsibilities of the vendors. For these to be successful, employers have to embrace this and provide the resources necessary for the vendor to do their job. So having those responsibilities in the contract should also be something to consider. And you'll see it in some of the proposed vendor language, particularly when we talk about performance guarantees, about requirements to communicate, market, provide access to employees, if not have data to the point about them having the information necessary to do their job. And from my perspective, I think it's entirely reasonable, and it's the best point in the process is to have that conversation up front, so that there's no surprises. That again, like you get 2 or 3 years in, utilization's third of what we hoped it would be. We want it to be clear what the role and responsibility of the employer is in this process, because it is a partnership, and that we shouldn't be shying away from that being in the contract, as much as that may be more of a difficult conversation.
Yeah, we'll actually have like teams, so the employer team and the vendor team, right? And then as part of that too, usually we like to have a dispute resolution process in there. I don't know if you're seeing that in a lot of
Yeah.
contracts, but a lot of times it's not just like going to mediation, arbitration, but it's like if there's an issue, it first goes to the operations director, and then for the employer, HR. If it's not resolved within 7 days, it's escalated. If it's not resolved within 14, we're going to meet with the CEO. We're going to sit down, and it's been really helpful in a few situations where we thought like, okay, there's going to be a lawsuit here, and this is going to be a total disaster and expensive. And through that dispute resolution process, once we could take it up a few levels, it's like, wait, there's just a personality conflict, right? Like we can work through this. So that's really helpful in addition to the teams, is knowing who's going to be working through those issues.
Yeah. Step 14 is really a repeat of step 9, so I won't go into too much detail on it. Again, you can't, it is one of the things that's mentioned by both employers as well as vendors as an issue. Like, I remember an early audit that I did when we first started doing this back in like 2009, and we were doing focus groups with employees and understanding like, why they weren't using the health center, were they aware of the services that were offered. And these were tenured employees that had used the health center multiple times and had access for multiple years. And so many times I heard them say, "Oh, I didn't know that the clinic did that," or I forgot that it did that. Like, you can't communicate enough. There needs to be a longitudinal, ongoing communication and marketing plan, and continually reevaluating: are we using the most effective modalities to engage the population, get the clinic staff out and engaging with the individuals outside of the clinic walls, use creative strategies, and there needs to be clear roles and responsibilities within the employer side to effectively manage that, as well as a vendor partner who understands how to most effectively communicate those services. So it's another area of partnership. And then the last step from ChatGPT is evaluation and adaptation. I generally would think about this as audit or assessment. And I think that it is something you need to plan for. And I think when you get to contracting, you need to make sure that you have audit rights, so that, because part of the audit and assessment process is the ability to dive under the hood and really understand what's happening at the organization, looking at data, doing focus groups, thinking about time studies, doing like a lot of creative assessment work to get to root cause of potential issues or things that are limiting a health center from reaching its full potential, operational, clinical, financial, and the ability to do that at the audit level is, I think, in my perspective, extremely important. And I think from what I see, vendors typically are doing audit work and they're not sharing the results with their employer partners. They're doing regular audits, chart audits, facility audits, and their vendor partners or the employer partners don't get to see that information. We think it should be a transparent process. Healthcare is messy. Clinics aren't perfect. There's always an evolution. And the most effective way is to clearly call out and mutually agree, these are issues that we want to improve on. How are we going to improve on those issues? Let's roll up our sleeves and do it. It can't happen in a vacuum. So having a clear plan, and this is part of that continuous improvement governance process, is to plan to audit, and make it transparent, and let's work on it. There's always opportunity to improve. We've done hundreds of audits, and I've never seen a perfect clinic, and it always produces over 100 opportunities. And then you have to kind of work through and just say, well, okay, we're going to be able to get to those things, but these things, aren't a high priority. They're less important. We're going to put them at the bottom of the list in the parking lot, but it needs to be part of the plan. So I do agree with ChatGPT on that, that it should be part of the kind of broader planning process. So before I share some thoughts on what it missed, any key things missing from your perspective? Yeah. Mm-hmm.
So they don't know to ask for a service because they don't know about it. So
Sure.
you could sort of prompt them that way, and then it got me thinking about, well, do you actually offer a template, a questionnaire template, as a consultant to a prospective client to say these are the considerations that would come together as you ask your employees about what services they would want.
Mm-hmm.
And so I'm sure there are other things that would go into deciding those services, but I thought maybe ChatGPT missed out on that. I mean, arriving at that would seem to me to be a really important piece to it, and it's sort of very high level.
Yeah, I think there's a couple different elements to think about in answering that question. First, I'd say there's so many different little details about a health center and how it can reach its full potential. So we try to ground ourselves, at least in my experience, that we do, that we're using evidence-based guidelines, third-party standards as the foundation for whatever model we're implementing. Most commonly, and I've referred to it today, is NCQA, Patient-Centered Medical Home, NAWHC, and there's hundreds of standards under their banners, and there's variants by service line about what they recommend. So operationally, having a PHQ, PHQ-9, a GAD-7, doing an HRA and having a comprehensive HRA that has specific criteria in it, those are fundamental pieces of an advanced primary care model. Or if you're having, even if you don't have carved out dedicated mental health, behavioral health services on site, that the providers are doing those screenings at the point of care, just as an example. So that's our foundation. And then with medical directors and the team and stakeholders that are in place in designing the specific custom employer model, they may layer in other things that are unique to that employer that a vendor may not offer, and that's unique to them. So a point solution, something that, and every employer has this, we've heard it earlier this morning, an array of other vendor partners that this clinic needs to integrate with, and that it can get down to individual testing. But I'd say it's typically not that detailed. It's typically left up to the clinic vendor manager and the protocols that they've put in place. We're evaluating what they do as part of the RFP process. Yep.
My experience with the Fortune 50 company is they do this clinic and they dump it on HR, who's overburdened
Yeah.
already, and maybe not qualified necessarily to understand the ins and outs of it. And
Yeah.
so they micromanage, don't have so it seems to me there needs to be a dedicated person. So if this Fortune 50 company spends $1 million a day in the United States on healthcare, why wouldn't you have a dedicated person to help monitor the health as opposed to, so what I would like to see is who owns the clinic from the employer standpoint.
Yeah. Yeah.
That's been a big issue.
No.
I had a case, this is years ago, where we actually did training for the HR director at a fairly large company
Yeah.
on compliance and legal issues with running a clinic, because she was literally showing up to see who was going in the clinic and like asking the nurse, and I mean, clearly like had issues, but it was a whole training that we worked with the broker, the employer, and legal on for HR on how they needed to handle this, right? Because
Yeah.
of those exact issues.
Yeah, I 100% agree. And having a conversation up front as we design the governance structure and the team, the stakeholders that need to be involved, carving out time for there to be somebody to be responsible for this, and setting expectations about the time that's necessary for it is critical. And it aligns with another piece of this, and these are items that I'd flagged that I saw as gaps in what ChatGPT recommended. And then this is from my vendor conversations around gaps that they saw, employers and employers and consultants, mistakes that they miss. Another element here, and we're about to run out of time, is having a documented plan. I talked about having goals and objectives documented up front, but having that being a living, breathing document, and because change is inevitable, and having a change management plan is a necessary component of this. And part of that is communicating to stakeholders and continuing to educate them about what the health center is. It's not just employees misunderstanding, it's the stakeholders, and they change, so they need to know, why was this put in? How does it function? How does it function most effectively? and make sure that stakeholders are giving it the oxygen that it needs. And we see over time that that goes away. Like, they make choices about access during business hours, or they make choices about, we can't communicate it like that anymore because, you know, it's competing with some other message, you know, company-wide that we want to give air to. Like, so there's a lot of different reasons why kind of the initial plan starts to degrade. And so you need to have that plan in place. And so when a new stakeholder comes on board, they don't just look at it and say, I don't want to spend $2 million on this. Like they understand the value proposition and why it's important to the organization. Yeah.
On the last slide, what was the sensitivity testing? What is that?
That's part of the feasibility modeling step, in that you come in and you may have rather than just saying we expect it to be 30% utilization in year one, like you don't really know what's going to happen when you open the doors. We've seen it. As much as we use best available information to guess, you don't know. So you have to plan for the best and as well as the worst, and say, you know, if we hit 80% utilization, how much space do we need? How many staff do we need? If we only get 10%, like what's our process to scale this back and manage that that loss? And at that point, it will be, you know, some level of a loss, or needing to reconfigure at that point. So we typically model, multiple scenarios controlling for different utilization and program impact to show both utilization outcomes as well as clinical and financial outcomes.